A blessed evening to one and all. I welcome one and all to the 5th Cardio-Obstetric Masterclass with yet another important topic for discussion, acute myocardial infarction in pregnancy. I now request our course director, Dr. Justin Paulser, to share a few words on cardio-obstetric masterclasses and on today's discussion.
Very good evening, all of you. Thank you for joining. It's a pleasure to have you all once again to be with you for this important program, Cardio-Obstetrics Masterclass, where every month we'll be discussing a case which is a heart disease complicating pregnancy. Heart disease complicating pregnancy has become the leading cause of maternal mortality in most of the developing countries. It is soon going to be the status in India. So we need to really work together, obstetricians, cardiologists, anesthetists, cardiac surgeons, electrophysiologists, maternal fetal consultants. All of us need to work together. And with this idea, we have started this Cardio-Obstetrics Masterclass, where we have specialists from all the fields. We'll join together and discuss a complex case, and we'll come out with the take-home messages so that all those who was working to improve the care of these unfortunate women with heart disease, so that we can give them a safe motherhood and healthy and happy life. This is a precise idea, and we have been discussing multitudes of cases earlier. We have discussed heart failure in pregnancy, pulmonary hypertension in pregnancy, and we have discussed high-risk heart diseases in pregnancy. And this time, we are discussing a case of acute myocardial infarction in pregnancy. And Dr. Jyotsna Maddury will be presenting a case of acute MI. And we have a distinguished team of panelists. I request Dr. Annie Princy to introduce the speaker and the panelists to the audience.
Thank you, sir. So I'm happy to introduce the panelists for today's session. Dr. Rupali Khanna, Professor, Department of Cardiology, ST-PGIMS, Lucknow. She was the past convener of CSI Heart Failure Subcouncil, the honorary editor, and past treasurer of UPCSI, section editor of Indian Journal of Cardiovascular Diseases in Women. She has numerous publications in her credit and has authored many books chapters. She has 60 research papers and case reports in peer-reviewed journals, besides several review articles published in national and international journals. Dr. Sampath Kumari, Professor and Head of the Department of Obstetrics and Gynecology, Sri Muthukumaran Medical College Hospital and Research Institute. She was the Vice President of FOGSI, National Corresponding Editor, Journal of Obstetrics and Gynecology of India, Founder Secretary, Tamil Nadu Federation of OG, Retired Director, Institute of Obstetrics and Gynecology, MMC, the President, Board of Studies, OG, Tamil Nadu, Dr. MJ Medical University, Chairperson of FOGSI Adolescent Heart Health Committee. Dr. N. Basker, HOD and Professor of Anesthesiology, ISO, Government KGH, RGGH, MMC, Chennai. He is the Nodal Officer, Tamil Nadu Maternal Death Audit. He has been the Honorary Secretary, Indian Society of Anesthesiologists, Chennai City Branch, and now the Honorary Secretary of Indian Society of Anesthesiology, Tamil Nadu State Branch. Dr. Jacob Jamesraj, Senior Consultant Cardiothoracic Surgeon, Madras Medical Mission, Chennai. Well-versed with a wide variety of cardiothoracic surgeries, he has presented more than 75 papers in national and international conferences and has conducted more than 25 workshops with a number of publications to his credit. Dr. C. Prabhakar Reddy, Additional Professor of Department of Clinical Pharmacology and Therapeutics, Nizam Institute of Medical Science, Hyderabad. Subject expert of Deputy DCG, Hyderabad Zone, in inspection, auditing clinical trial site and CROs, ethics committee auditing and investigation for serious adverse event since 2013. So I would now like to introduce the presenter of the day, Dr. Madhury Doshna, retired professor and HOD of Cardiology, Nizam Institute of Medical Science, Hyderabad. She has more than 150 publications and authored many books. She has been awarded the Certificate of Recognition Award from National Health Authority, Health Trust 2022, the Outstanding Scientist Award in 2022, the Women of Excellence Award 2022, Women Leadership Award 2020, and the Best Women Researcher Award in 2019. always energetic interventional cardiologist. Welcome, ma'am. So I now hand over the session, Acute Myocardial Infarction in Pregnancy, to today's moderator and our host director, Dr. Justin Pulser. Before that, I would request the audience to post your questions, and we will be looking forward to answering your queries during the panel discussion. We'll be also having a live Q&A session after the lecture. Over to you, sir.
It is really nice to have a great distinguished panelists who are legends in their own field to come and share with us their expertise on managing an acute myocardial infarction pregnancy. And as Dr. Annie said, please be tuned to whatever is being told, and you're welcome to share your comments. In fact, we understand and we recognize that we have distinguished members in the audience. In fact, you have been panelists here, you have been speakers here. Your inputs are very important. So in the chat boxes, not only your queries and comments, your answers and your suggestions, everything are welcome in the chat box. We'll be looking at the chat box and responding to you. Thank you so much. And with this, I request Dr. Maddury to present the case, and Dr. Annie will be sharing the slides.
Hello. Good evening, sir, and welcome to all the people who have the interest in the cardio-obstetrics. Actually, this is the idea, we got it with the WINCARS Association, which you already people know about it. And we published the articles on the cardio-obstetrics in 2015 itself. And I'm very, very happy now Dr. Paul sir has taken the idea and is taking it in a big way to go forward. So today, my case discussion is on acute coronary syndrome in a pregnant young woman. Can I have the next slide, please? She's about a 30-year-old female. She is a second gravida. She pair of one, and she has a one live child previously. First time presentation at the time her gestation was 32 weeks. She had a gestational diabetes in the first pregnancy, that is nearly about 3 years back. But after the delivery, there is no follow-up either for the diabetic status or the patient condition. Only one prenatal visit during this pregnancy also. That was done in the 5th month. And we don't have any records except the patient saying that she went to an obstetrician. They recorded the BP, but they not tested the sugar, and it was a normal. And no blood test was done despite the advice. And now her presentation is at the 32 weeks. The no blood tests were done despite the advice. And now she came to the emergency department of the tertiary care center, that is to the Nizams, with the chest pain associated with the diaphoresis, with the window period of the 12 hours. It was a classical central chest pain associated with the diaphoresis, but it was a bearable. So she thought that is not related, and mostly as other females think that there are non-cardiac pain, she also thought that it is a indigestion problem, and she experienced similar types of the pains during her previous pregnancy also. So that's why she has not reported to the ED. Then when she came, she was looking a little bit pale. Pulse rate was about 90 per minute, but regular. Respiratory rate was 20 per minute, comfortable in the lying down posture. BP was 90 by 50 at the borderline. All peripheral pulses are well felt. And the heart examination, S1 and S2 heard her, and there are no murmurs. Lungs were normal, there are no added sounds. Within the 5 minutes, because her main complaint is the chest pain, ECG was taken. This is the first ECG in the emergency department, which is showing ST elevation in the V1, V2, V3, V4, and in AVL, and slightly in the 1 also. And the reciprocal changes in the inferior leads are seen, which is confirming anterior MI, acute anterior MI.
So we can launch the poll. Webinar team, Madam will be launching a poll. I request all the audience to participate.
Yeah.
So you're able to see the options, you can choose the options.
What is the probable cause of this acute MI? Whether it is atherosclerosis or a spontaneous coronary artery dissection, vasospasm, in situ thrombosis, or any one of the above?
We give 20 seconds. You can show the results.
Yeah, it's a good poll. And just coming to the answer, it could be any one of the above is a more appropriate. Because as we already know, the coronary artery disease, especially during the pregnancy, can be any one of the above said conditions. Previously, atherosclerosis was slightly the more in the last decade than in this decade. So that was almost contributing to the 30 to 45%. But now in this decade, almost a spontaneous coronary artery dissection as well as the atherosclerosis has become almost equal incidence. Whereas vasospasm contributes to the as variable in the different studies from 3% to 13%, and in situ thrombosis is known to occur the 5 to 7%. It is variable in the different situations because it is a prothrombotic state, the pregnancy. So in situ thrombosis is also known to occur. Not only that, in addition, coronary embolism as a presentation of the acute MI is also then another condition which has to be considered during the pregnancy.
Next slide.
So basically the ECG is showing an acute and anterior MI. So other investigations done very fastly before taking the consultations of the different areas in the emergency itself. The random sugar showed 190 milligrams per deciliter. Only hemoglobin can be done on spot. So that it came as a 7.8 grams per deciliter. And HbA1c actually we received after the procedure. For the completion sake, we are added at present here. That is 7.2. It is diabetic range, but not very badly uncontrolled diabetes. And TROP-T is significantly elevated, 15 nanograms per ml. And immediately the ultrasound was done. In addition to the hearing of the fetal heart sounds, ultrasound has also demonstrated presence of the viable fetus. And before the shifting the patient to the emergency side on the cardiology, 2D echogram are also done, which is showing a regional wall motion abnormality in the LAD territory with the ejection fraction of 34%, that is moderately decreased left ventricular function, mild mitral regurgitation, a trivial echo-free space in the anterior pericardium.
So we can launch the next poll now. Yeah, now we have seen what is the etiology, what are the possible etiologies Dr. Jyotsna has clearly shared to you. You can start voting or making your options. About 35 to 55% is atherosclerosis, 25 to 43% is SCAD, and others are minor in the recent data that we have. So having that in mind, please make your options. Then we'll have the panelists discuss the various possible solutions to you. Yeah, fine. I think many of you, I think people are still voting. I think, glad I think you are sharing now, able to see. This also can be live, good. I think we have a good participation, almost 3/4 of the participants have voted. We really appreciate that. And thank you for your support. And now we can stop the poll. Now we'll have a break for discussion, and you can stop sharing the slides, and you can pin those who are speaking probably. Dr. Jyotsna, would you like to analyze the echo findings? Do you prefer any other additional information at this point of time? Any other consultations or testings that you will be doing?
Yeah, it is again, I have to answer the same thing which I faced in the ED. Okay. So what is a major important thing in the 2D echo? There is a controversy that we should keep the needle door time to the as short as possible. So all these investigations is required or not? That is the first question. But in this case, yes. And however the fast you can do it, doing a 2D echo definitely will add to the additional findings in the case of the acute MI. So you consider these description of the echo findings. That is regional wall motion abnormality in the LAD territory, which is a finding in the case of the acute MI. So that already says that it is slightly gone beyond an hyperacute stage. Even though the history-wise we had that nearly the 12 hours, and ECG is still the ST segment elevations are really looking like an hyperacute. But the thing is, reasonable abnormalities are already established in an echo. It slightly says that is a prolonged ischemia is present. That is the first thing. And second one, ejection fraction, even though with all the fallacies, the ejection fraction may not be reliable to know the LV dysfunction, but is fairly okay in an emergency situation to know what is the severity of the LV dysfunction. That will determine should we require any other supports other than the hemodynamics, which are clinically detected. ECHO also will add information to us. And a few of the important positive findings and negative findings required to be highlighted in the case of the acute MI. Like we should tell that an LV thrombus is there or not, which is not mentioned in this. That's the reason why I said that any other information is required, because it is as short as 6 hours of hypokinesia on echo is good enough to develop a thrombus. So that is not mentioned. And which is mentioned is a mild MR. Because in the inferior MI, usually we see that the papillary muscle dysfunction or even sometimes rupture can lead into a significant MR, and we give importance, but that is true even in the case of the anterior MI. This could be because of the papillary muscle abnormality or rapidly acute dilatation of the left ventricular also. So the severity of the MR has to be the mention. Another important thing is because it is already beyond the 12 hours, even though the ventricular septal ruptures are the common after the delayed thrombolysis, but after the 12 hours, the VSDs are known to develop. So it is worth mentioning that there are no murmurs on the clinically, and the echocardiography wise, you are not able to detect. But actually, we have to rely more on the clinical examination in this, because these murmurs, they're very soft, but still they are audible. And sometimes if the echo findings, you are not able to go more posteriorly to demonstrate it, you may be missing the VSDs. So the combination of the clinical as well as echo findings are important. And I wanted to come to the last component of this echo-free space. In this case, why I want to give an importance is, whenever the acute MI, there is an echo-free space, first thing to be considered is the pericardial effusion. But it is specifically mentioned that is to the anterior to the RV. So that says that so localized pericardial effusion is very, very rare unless a previous surgery is done or a previous trauma is occurred or previous fibrosis like a tuberculosis, some other conditions is responsible. So local pericardial effusion containing to the only to the anterior to the RV is less likely. But in acute MI, pericardial effusion has to be given importance, because especially within a 24 hours is not related to the inflammatory as an inflammation because of the MI producing it. So it is not a dressless. So we have to think that the complications of the acute MI can be leading to that. Like sometimes extensive anterior MI itself can have the reactionary pericardial effusion, and most important thing is a small rupture into the pericardial space, which can be contained rupture. So you need not to have a cardiac tamponade every time to have it. You can have a contained ruptures and you can have the pericardial effusion. So we have to see that. In this case, specifically it is mentioned to the anterior RV, and it is not presented because it's there is no previous history. You expect to be general pericardial cavity, which is not confined to the only to the anterior to the RV. It is less likely that this is the pericardial effusion. So then what is another possibility? Now the concept of this in epicardial, pericardial, paracardiac fat is having a very, very high level. That's the reason why I wanted to concentrate on this point of it. These names are the different, like if it is in between the pericardial layers, pericardial, if it is an epicardial between the visceral and the myocardium, and it is in a paracardiac, it is beyond the fibrous pericardium. All those things can be distinguished by the echo. But in an emergency echo, you imagine that it is not a high quality echoes which we get it. So you, in this case, is relevant to know, because she has the other coronary artery risk factors other than the pregnancy. Like she has a gestational diabetes, which was not treated properly, whether she is established as a diabetes as an additional component to this for the presentation in acute MI, we get a clue by this. There are the different studies showing that this epicardial, pericardial, which is the combination of the paracardiac and epicardial combination, but the different quotations are given. On the fairly, it is more than 5 mm thickness usually be considered. So another important thing we have to ask whenever there is this so-called pericardial fat is there, what is the thickness of the pericardial fat? Because this is directly associated with the coronary artery disease. So of course, ectopic pericardial fat also someone described. I don't think it is relevant here to talk about it.
Exactly. I think Madam has given a very clear description of the findings and what are the investigations that are necessary. And there was a question whether echocardiogram is routinely necessary or not. In an acute MI being shifted to the cath lab, if you can have an echocardiogram done along the way without delaying the time window, it is fine. Or if it is going to delay the time window, you don't really have to do it. Most importantly, I think we need to do it in time. Dr. Anbu has asked the question, we have answered it here. Now, I request Dr. Roopali to explain to us on how or what will be the revascularization mode that she will choose. We saw the audience, most of them chose interventional and some of them chose the thrombolytic therapy. So Dr. Roopali, how will you choose between thrombolysis and primary PCI, and why will you choose that?
Good evening, everyone. I think ma'am very well explained the MI causes in this, but if we see this patient particularly, she came to us after 12 hours of window period, pain ongoing. Now we are dealing with two questions. One is acute MI along with a pregnant female of 32 weeks pregnancy. Now she already 12 hours passed. Should we go for a thrombolytic therapy in a pregnant female? Because we have been shown that in thrombolysis therapy, there will be increased risk of hemorrhage. Like either can be a maternal hemorrhage or fetal hemorrhages, especially if it's 32 weeks that patient have said emergency delivery or some to fetal distress happens, then going for immediate delivery will again cause a risk for both the mother and the fetus. So if it's a primary PCI incapable center, it's always better to take these patients for PCI in these cases. And the issue with PCI, like there is a worry about radiation, safety and all that. Because if we see she's already caused a third trimester. In first trimester, there is an issue of your radiation injury. And the amount of radiation which we give during coronary angiogram is very low. Because if we say it's less than 1 millisievert or something like that, and it's better for a damage to the fetus or any distress where maybe more than 50 millisieverts have been shown. So the risk, if you're PCI capable center, it's always better to go for a PCI in these cases rather going for thrombolysis, because as already shown, it's not always thrombosis, because in these cases, patients some might have SCAD. And we all know that 1/3 of cases with pregnancy is where we are dealing with SCAD. So it's very difficult to differentiate between these two entities. And other option is like sometimes I just missed one during discussion, can I Takotsubo cardiomyopathy? Sometimes in pregnant females with stress and all that, we have really seen sometimes Takotsubo cardiomyopathy also. So if possible, it's better to go for a PCI. But if it's incapable center and we don't have any other option, then thrombolysis. But the risk should be explained to both the patient and to the mother that there will be increased risk for going for your fetal distress, fetal hemorrhage or maternal hemorrhage.
Is there any clinical clue that will help you to identify whether this is SCAD or atherosclerosis? I know it is difficult, but there is a question in the chat box. What is your comment on that?
So I think there will be like only the history. If there is no other risk factor and she is pregnant, it's as already shown 30 to 40% case will be SCAD. So like in our case, there was a history of diabetes and maybe dyslipidemia. She might be atherosclerotic. We cannot rule out. But if it's a young female, then more chances of SCAD. It's only the clinical features we can comment on.
Exactly. I think the question may not arise much, but if you're in an interventional center, the only issue happens is if you're in a non-interventional center and are we safe to thrombolyze? So that is the concern I think some of you will be having it.
I think if the patient is stable enough, sir, then the patient should be referred to a PCI capable center rather than thrombolysis in these cases.
Exactly. So I think we are taking a lot of time on this discussion break. We'll call the obstetrician also here. Dr. Sampath Kumari is here. And how would you proceed further in this case? Will you call a fetal specialist or somebody here And what will be the advice you will be giving to the cardiologist? The patient is 32 weeks, has come to the emergency, and cardiologist is primarily taking now. He has called you for opinion. What are the inputs they will be giving the cardiologist? And how are you going to advise him further? I think
Thank you for the opportunity. And more or less, this myocardial infarction during pregnancy is very, very rare, sir, nowadays. But since the case has been done, but I don't know this case. Now she is 32 weeks and she had only 5th month prenatal visit. Normally, in the first visit itself, we will see whether she is already in the previous pregnancy, she was DDM. She is the high risk pregnancy. Hemoglobin is also 7.8. Random blood sugar 190. So this diabetes has to be corrected. Since we don't have the time, we may not be able to get the diabetologist opinion. Once the procedure is over, patient has to be started on the insulin or whatever it is. Then the hemoglobin 7.8. Again, for this, we routinely go for a blood transfusion. But since it's for invasive procedure or whatever it is, if there is no time, once the procedure is over, we can correct that anemia. And patient is having pain. So I wanted to do the per vaginal examination, definitely, whether the patient is having labor pain or other pain. So if she is in labor, since she is 32 weeks, I think I will do with the PVE examination, and I'll also take this opportunity to assess her pelvis. So as far as possible, now per vaginal examination can be done. Once the procedure is over, anemia has to be corrected and blood sugar has to be corrected. And if there is time for us to do something for 30 minutes or like that, with the portable CTG, I want to know the assessment of the fetus if time permits. And normally we don't get the fetal therapy pediatrician's opinion at 32 weeks. So it is not necessary at 32 weeks. And according to what is the instructions to the cardiologist, if the patient is going to be continuing there, if the patient complains of any further pain in the lower abdominal pain, and if she gives any history of bleeding or any, sometimes premature rupture of the membranes can also occur. So if any of this condition, if the patient complains, we would like the cardiologist to call us. Most probably with these situations, I think one of the cardiologist, one of the physician will be there, because we cannot just like that leave and go to our ward. This is the opinion, sir. But in these situations, I don't know why this patient didn't have proper antenatal checkup. Normally in our place, we are doing echo. Routine echo is done for all antenatal patients, whether they are cardiac patients, and that too you only promoted with all the government hospital. Now it is done everywhere. So if it has been done, we could have an idea of about what is happening to her. But now routinely it is done at 20 weeks, whether it is government, corporate, private, wherever it is. So this is the situation, sir. But it is a very, very high risk case. I want to talk to the attenders also. Thank you, sir.
Thank you, madam. I think, and now I think, yeah, Annie has posted the third poll. Fine. So there was one question in the audience whether conservative management, probably will come to that, and need for setting up a cardio-obstetric heart team in managing STEMI and its complications during pregnancy in Indian setup. It is very, very important in Indian setup that we obstetricians and cardiologists work together. As Dr. Sampath Kumari rightly pointed out, I think you can, as I'm talking, you can start voting for it. Dr. Sampath Kumari rightly pointed out this obstetrician's presence in the cath lab is very important for us, not only the cath lab, in the cardiac emergency for this patient, because she is 32 weeks at a fetal viability, she may go in for labor anytime, and we may need to take care of that. So we always need to work as a team, and even whichever institution you are in, if you do not have a cardio-obstetric team, please create one today. And thank you for this question. And now we have, I think, 60% have answered, 50% have answered. We'll wait for a few seconds. Is pregnancy a contraindication to thrombolysis? Now we have a pharmacology professor here and a clinical specialist, Dr. Prabhakar. So I would like him to discuss the answer to this question once we close the poll. So you can stop the poll, and we find that most of them have felt it is a relative contraindication, and some of them have felt it is an absolute contraindication, and some of them have felt it is not a contraindication. So, Dr. Prabhakar, what do you feel?
Yeah,
Is
yes.
pregnancy a contraindication to thrombolytic therapy? Can you explain?
So, good evening. So, thrombolysis, the most important factor in pregnancy for the effect on fetus is placental transfer of the drug from maternal to fetal side. So, most of the times, any drug with a molecular weight of more than 1000, it is very difficult to cross the placenta. And most of the times, the thrombolytics, the molecular weight is more than 10,000. So the chances of crossing of these thrombolytics through the placental barrier is very, very, very less. So what they do is, however, when we want to use thrombolytics in pregnancy with MI, they advise only streptokinase and TPA. However, these streptokinase and TPA are associated with adverse maternofetal outcome. So these two things are relatively contraindicated in pregnancy. They're not absolutely, but they're relatively contraindicated in pregnancy. But when we come to urokinase and RTPA, these are absolutely not recommended for thrombolysis in pregnancy.
So thank you, Dr. Prabhakar Reddy. One more question to you. These women are generally more prone for bleeding. And, do we have any doses adjustments for these drugs? Do we need to do any adjustments during pregnancy, or you don't need to?
No, as when I was reading for the last 2 days, in most of the drugs in pregnancy for MI, there's only thing suggested for fractionated heparin. Other than this fractionated low molecular weight heparin, there is no dose suggested for in pregnancy.
Okay, thank you. And Dr. Roopali, because we have been talking about thrombolytic therapy, not every center will have a cath lab. There are definitely a lot of centers which do not have a cath lab, and they also will have to manage acute MI during pregnancy. Well, let us just talk about pregnancy and thrombolytic therapy, not necessarily always due to acute MI. Can you share some data on pregnancy and thrombolytic therapy? Is it safe?
See, there have been some data on like pulmonary embolism happening in pregnancy. So the fibrinolytic therapy have been used in these cases, and they have been shown relatively safe. The only issue in this case is she's already 32 weeks pregnant with low hemoglobin. So if she goes into labor, that is the only challenge that which we might face, that she might go into maternal bleeding or hemorrhage in this case. Otherwise, it's not an absolute contraindication. But if the patient is hemodynamically stable and we think that pain is still can be managed with conservative management, and it's a PCI incapable center. So it's better to do a conservative management rather going for thrombolysis in particular this case. Otherwise, there has been data with the especially pulmonary embolism cases, and it has shown to be relatively safer. But as sir also said, there will be increased risk of maternal bleeding and fetal outcomes are poor in these cases.
Thank you, Dr. Roopali. Dr. Jyotsna, I think I left one question with you. Which route you would like to take, considering radiation safety for this patient? You would like to go radial or femoral?
Yeah, of course. Once we are, everyone voted for the invasive, and we also did the invasive way of management of this patient. So the patient was shifted to the cath lab. So now the problem is which route to do it. So I'm very certain that everyone will vote for the radial. The radial is not only for the maternal cause, for the fetal cause also. First, we'll see the fetal cause. The radial artery, the exposure, the puncture, doing the procedure, everything is slightly difficult than the femoral. But nowadays, many people doesn't accept it. It is mainly operators which will decide which route to be taken. The major advantage for the fetal cause is decreases the radiation. If you are directly going for the femoral, the direct exposure of the catheter and the wire, at least till the placement of the engagement, you require the fluoroscopy. So that radiation will be the more to the patient. So to decrease the fluoro time and the fetal radiation, radial route is definitely better for the fetus. Second one, coming to the maternal advantages. Maternal advantage is many things, especially when the patient is anemic. In a female, pregnant, anemia, complications rates are very, very high with the femoral access. So to prevent that vascular complications related problem, especially in anemic, we require the radial route. Not only that, maintenance of the left lateral position. Sometimes the patient may become then unstable or then hypotensive. Then we have to turn her to the left lateral even during the procedure. That is possible with the radial, but it is not possible with the femoral. And after the procedure, the comfort to the female. She can sit up, she can even walk. Actually, when we started the radial procedure, we used to demonstrate to the other people. We used to ask the patient to get up, and walk to the outside, even though we are very certain that it is not a safe to walk immediately after the ionic contrast and everything. But to tell the comfort to the patient, we used to say that. So the patient will have the very much good comfort. So definitely radial route. And second question of yours is the radiation protection. What radiation protection we have to take about it. Actually, theoretically talking, in usually the intervention, including the stent implantation, it causes the radiation of about 3 milligauss, or if you want it in millisieverts, it's a 0.1 to 0.02 to 0.1 millisieverts. So which is not either teratogenic or a problematic either to the fetus or to the mother. But all said and done, we should decrease the radiation exposure. For that, we should use the shields. The another component of the shield everyone says is the fetus is not in the direct field of the radiation. The direct radiation, if you are doing a radial, is to the heart, not to the fetus. So what is the fetus is getting the scattered radiation. So if you're putting a shields, it gives a more protection to the surrounding people than to the fetus. But all said and done, yes, still that is recommended you use the abdominal shields. Because if the abdominal shield, the degree of radiation is proved to be the less. And second one is we should use the less fluoro time as far as possible and less cine time. Cine time, if a cine takes more the radiation than the fluoro. So try to do everything under the fluoro, but not under cine films, because it's our natural tendency in intervention to go for a cine to have a proper and better delineation. So when you are not very certain, then only go for a cine mode. Otherwise, try to do only under the fluoroscopies. And another important thing is about the ionic contrast. The ionic contrast also causes the radiation, but the amount of the radiation produced by it is so less. But up to the extent that some people said that this may be excreted even in the milk sometimes if the patient is already lactating. So better to avoid the day when the procedure is done. So all those things are there, but all said and done, it is not even a concern about it.
Yes, madam. I think your message is very loud and clear. The route to safest is radial, and the radiation dose during a cath lab procedure is very insignificant for a fetus. So we'll go back to the case. Annie, you can show the next slide. The previous one, yeah.
So
this was the previous, yeah. Dr. Jyotsna?
Yeah, in the cath lab, we give the all loading doses as usual, what to do it in an acute MI, as we are not adjusted the any drug doses in this patient. So loading dose of statins were given, that is an atorvastatin was given for this patient, even though other than the in this condition, relative is the contraindication to give the statins, aspirin 325 milligrams, dual plated drugs are given, clopidogrel 600 milligrams, atorvastatin 40 milligrams, anticoagulant 5000 units, that is heparin, conventional heparin was used. So after that, the patient was shifted to the cath lab and the radial root coronary angiogram was performed. This is the angiogram, static image of the angiogram, which is showing the left main is normal, circumflex is in a codominant and normal. LAD at the mid segment, there is a narrowing is present nearly about an 18 mm, including the first diagonal branch, which is of an intermediate size.
So, right. So we'll have a break here now. What will be your preferred, why did you choose invasive line of management? And why did you choose, will you consider imaging during PCI? Dr. Jyotsna, I think since you have done the case, you can answer this too. Why did you choose invasive line of management? I think Dr. Roopali has already covered this. Maybe we can skip that. So will you consider imaging, and why would you, if yes, and what are your concerns?
Yeah, definitely imaging is the indication in this present case. The major reason why invasive procedure is chosen is to know what is the type of the disease the patient is suffering. That will determine what type of the subsequent management we are going to do it. So in all MIs, we may not require the real imaging, especially in Indian circumstances with the money constraints and the complications of them using an extra contrast to the imaging. All those things has to be taken into consideration. But in this case, imaging is going to add our management. So we should able to distinguish between the SCAD versus atherosclerosis, a thrombus, embolism. Embolism, we may not able to do it. All other conditions we can distinguish from that. So that's the reason imaging is mandatory, not only to diagnose, even to know the length of the stent if you are going for a invasive procedure subsequently. Because if it is a SCAD, just diagnosis SCAD is not sufficient. What is the hematoma size and how much it is compressing the lumen? What is the length of the hematoma and what is the stent of the size of the stent? Because usually normal area to the normal area, stent implantation is good enough after doing an imaging, but not in the case of a SCAD. Suppose if you have an 18 mm of the SCAD present, you require a longer length of the stent. You require a 24. So you require even the length. So character, the type, diagnosis of the SCAD, it gives an importance for the management by doing an imaging.
Thank you, Dr. Jyotsna. I think you have talked about the importance of imaging during the procedure, but however, there are always concerns about taking any hardware during, particularly in a SCAD, which can promote or trigger further dissection. Now, let me ask Dr. Roopali, what will be the choice of antiplatelet therapy in this patient, and how long will you be continuing? And maybe you can also answer the next question. What will be the role of cardiac surgeon here? When will you consider calling a cardiac surgeon for your case?
Sir, antiplatelet, like ma'am also showed, the aspirin should be given in these cases. The newer antiplatelets, like ticagrelor and prasugrel, there has been no data and there has been shown that maybe increased bleeding rates, the higher antiplatelets should be avoided. So clopidogrel should be given in these patients. The other drug therapy like beta blocker have to be given in these cases. Statin data, we really don't have data because if we see the class of recommendation according to pregnancy, the statins are usually not recommended in these cases, in pregnancy, sorry. And but this is an acute MI which we are dealing with. So statins should be given. The only statin which have been in pregnant females which have been done is a pravastatin, because there was some studies which was done with, especially in preeclampsia patients, because pravastatin considered to be hydrophilic in nature. So a pravastatin, if it's available, so because less crosses the placenta, so has been shown that pravastatin to be given in these cases. Now, the duration of the dual antiplatelet therapy will depend on the strategy which we are going to do. If you're going to implant a stent, then obviously our duration will be more. And if you are not going to implant a stent, we go for it's a SCAD, then we can shorten the dual antiplatelet therapy. Now, whether to intervene in this case or not, because it's a still image, so we are not very clear whether it was a TIMI3 flow or it was just having a TIMI2 flow in this case. So we are seeing an 80% stenosis. So if it's a TIMI3 flow, so should we go for a stenting in this case or a conservative strategy? It will depend on the patient hemodynamic status, and the other is the imaging if it is showing. As you rightly pointed out in SCAD, doing imaging, passing the wire, we have to be very careful, because if we are dealing with a dissection and if our wire goes into any flap-like thing, it will become a very challenging situation in these cases. For a surgeon's view, like all the cases which we see in our routine angio also, if it is a left main disease or we having a multi-vessel involvement and we are seeing that patient is having a long lesions with left main with lesions with this, then a surgeon might be called, but because in pregnancy, going any procedure for surgery, patient going on pump will have an increased mortality, both the mother and the fetus. So until unless we see it's not a PCI amenable patient, then only these patients should be referred for the surgeon. Or if it's a left main disease or a multi-vessel SCAD causing TB2 flow and hemodynamic or electrical instability in these cases, then definitely a cardiac surgeon will be of great help.
I think Roopali really made a very important point that if the patient is hemodynamically stable, there is no chest pain, and there is a good TIMI3 flow, conservative management is the best for the patient. Despite that, a critical lesion may be there. I think there is a very important take-home point that we need to have, particularly because dissections scared during pregnancy. If you're stenting it, the incidence of dissections extending and proximally as well as distally is to the level of 10 to 15%. And many times, in fact, it's always good to have a cardiac surgeon because dissections have extended to left main circumflex, and surgeons have really jumped into the field to support the patient. Now we have a cardiac surgeon, Dr. Jamesraj. So I would like to ask you, in this case or a similar case like this, when would you like to intervene here, or what will you think, what kind of supportive role you can present, you can offer for this patient, and what will be your concerns if you need to operate this patient?
Thanks for the opportunity, Dr. Justin Paul. It's actually a very interesting discussion that has been going on for the last 3/4 of an hour or so. We have a lady who is 32 weeks pregnant. Looks like she is infarcted, and she's completed her infarct. She's got an eminently angioplastable LAD. This particular case doesn't give us much of a thing to debate. But then, when does a surgeon intervene? When do we support? We always support. We are always there. When do we intervene? We need to view this from the mother's point of view and from the baby or the fetus point of view. So viewing things from the mother, I think it's important that we philosophically say that, we will save the mother no matter what. And then, you save the baby when it's possible. To have a live mom and a live baby at the end of your intervention or your management, with or without intervention, is the most desired outcome. Now, how do we get to that? When do we intervene from a mother's point of view? From a mother's point of view, if it's a failed PCI and the cardiologists feel that revascularization is needed, then we do have to intervene. If it's a left main, if it's a very calcified lesion, you elect that, PCI may not be appropriate, but then, there is the situation requires revascularization, then we can intervene and we can do it. The other more difficult situations are when there is a mechanical complication. If it's an acute MR from a papillary muscle dysfunction or a rupture, or, if there is a VSR or a cardiac rupture, you definitely have to intervene to save the mother. You have no other option. A post-infarct angina, it's very difficult to, to clinically say what is a post-infarct angina, whether it could be an impending rupture or an impending mechanical event. But then, in that sort of a situation, again, you may be forced to intervene. Failed thrombolysis is again another thing that we need to think about. The other things that we would probably think about is life-threatening arrhythmias. You are not able to manage it medically, whether revascularization will actually help, reverting, that's again another thing which we need to think about. So these are all the various situations where a cardiac surgeon might be called for, and then we might need to help. From a fetus point of view, I think my previous speaker mentioned going on pump would mean maternal loss and fetal loss. Well, it's only a CABG, so we really don't need to go on pump unless, of course, the patient is hemodynamically unstable and we are not able to stabilize the patient, which is a very rare situation. These days, we do all our cases on a beating heart. The fetal loss usually comes about when we get the patient onto a pump. We have to cool the patient, or we have to go into a non-pulsatile flow, which is when the uterus and the fetal-placental unit reacts unfavorably. And even if we have to go on pump, we can still have a pulsatile perfusion where we don't need to cool the patient. So, but for a CABG, we would not go on a pump. So the fetus could be or would be safer. And anesthetist on the board probably could tell us a bit more about if anesthesia would affect these things as well, because we need to, talk about both together. If there is a fetal distress, if, we need to get the maternal hemodynamics better, whether a revascularization would help. These are all other things that we need to think about. If the cardiologist feels that revascularization would definitely help, we can do that. We can also use an intra-aortic balloon pump to, to stabilize and do it rather than go on pump to do these things, even if the patient is not very stable. I'm not really sure if IABP has been used in a pregnant situation. Most of the evidence that we have for the discussions that we do from as cardiac surgeons is mostly level 5 or at the most 4. So from whatever we know and we believe could help, I think that is another thing that might help. For a completion sake, I might mention an ECMO, but that I think personally would be a disaster. We would definitely have a fetal loss. But then, if we need to use that to avoid a maternal loss, then maybe that's another thing that we could use as well. So I think, Dr. Paul, I think we have kind of talked about all the things that a surgeon could offer.
You have done a great job, Dr. Jacob. And in fact, cardiogenic shock, the incidence of cardiogenic shock in pregnancy-related acute MI is much higher than the cardiogenic shock in routine MI in non-pregnant women. So
at least twice.
Exactly. So cases where IABP have been used and ECMO has been used to save the mother's life in particular, and as Dr. Jacob pointed out, they are of course associated with the high incidence of fetal loss. And I think, Dr. Jacob, did you find any good published literature on this pregnancy and CABG in MI?
Most literature which I came across were only case studies, and such cohort-based studies are hardly evidence for us to derive conclusions from. Fetal loss, especially if it were the pregnancy was less than 28 weeks, was almost 100%. About 32 weeks, there are some case reports where people elected to do a cesarean section and then revascularize as well. So the experience is varied. I'm not really sure how much we could draw conclusions from. I suppose we just have to go on our own hunch and at that time talk to friends and come to a reasonable conclusion to help these patients.
There are some recommendations based on case reports. In fact, CABG performed between 13 to 26 weeks of gestation confers the best outcome for surgical revascularization. However, the gestational age is more than 28. An emergent delivery before CABG can be considered, or rather better considered, preferably under general anesthesia. This was a recommendation in one of the guidelines that came this year, again based on expert opinion and isolated case reports. And the risk of fetal loss estimated to be as high as 25 to 40%, and maternal mortality about 2 to 3% during pregnancy, MI, and CABG. So now let us go back into the case. I think we are getting late. Annie, can you present the slides? Go to the follow-up for it. Dr. Annie, can you present the slides? Are you there? Okay, then. Yeah, you can present the slides. Next 2 slides.
Then we took the OCT. That was the recently introduced to our institution. This is nearly a decade back. So that's the reason the image is like that. So left main and circumflex were normal, and SCAD is approved with a flap and intramural hematoma, which is almost occupying the volume of about nearly the 3/4 of the circle. and compressing the lumen, but it is very regular one. So this hematoma is confined to the lesion area, and the length of the lesion from the flap area to the normal area is about 18 mm length. Can I have the next slide, please?
Next, Annie. Next.
Yeah, I wanted to add one more point here. We took a city surgeon opinion, and we have to discuss with the patient attendants at this stage. One thing is, if we want to do an intervention, there is a specific additional risk associated with the SCAD with the intervention. That is, increase the risk of the secondary iatrogenic dissection. As we already told, even the guide engagement itself may likely to produce the nitrogenic dissection. As Roopali said, the passing the guide wire into the false lumen, which causes the extension of the lesion, and the proximal and the distal false lumen propagation during the implantation. That's the reason why we have to take a longer length of the stent. And persistent distal dissection. There are some people will say that you cover only the proximal dissection flap, so that that collapses the hematoma component, and distal flap will be covered. So even persistent distal dissection may be another one. And major side branch occlusion, as we have seen exactly at the same site, intermediate sized diagonal is coming. So we have taken the CT surgeon's opinion as a standby. After the stent implantation, if any problem
We need to move forward. We are getting quite late.
Okay.
We'll go to the next slide. Yeah. Is there a poll after this? The patient was asymptomatic and functional class 1 and repeat echo. Yeah. Yeah, please show the previous slide. Show the previous one. Is this a next. Yeah, great. The patient is asymptomatic, functional class, and repeat echo shows LV ejection fraction 45%. There is an improvement of ejection fraction, and the hemoglobin has improved to 9.4 grams percentage. Now go back. Now let us ask the obstetrician. You can go back to the previous slide. Let us stay there. 36 weeks, and she has a hemoglobin of 9.4. I think the obstetrician must have given good amount of hemogenics. So what will be your preferred mode of delivery in this patient? And what will be your advice to the cardiologist, and what will be the support that you will expect from a cardiologist? Dr. Sampath, Kumari, can you give your inputs?
Yes, sir. This patient, I think she is a very lucky patient, sir. Had a good and hemoglobin has improved 9.4, and ejection fraction also has improved. Since now she is, I think, 36 weeks. So we can wait. In now the condition is very stable, means we would like to wait for one more week, 37 weeks. And if everything is stable, means if at all needed, we will go with the Foley's catheter induction mode of delivery, if everything is okay. So if the patient is not stable and it has to be delivered immediately, we have to Foley's catheter. If it's that is the mechanical method, we will wait for 24 hours. If there is no prognosis, directly we will go for an LSCS. No medical induction of methods will be followed for this patient. Only mechanical can be tried. Other than that, other inductions will not be tried. So if at all needed, we will go with the completion of 37 weeks under epidural anesthesia. LSCS will be done. That will be ideal. If there is no progress with the Foley's catheter. If the patient is progressing with the Foley's, we will inject the mechanical dilatations, and we will watch after 12 hours. If there is the progress, means with a small dose of oxytocin, and if the pelvis is good and the baby is small, we can go for the vaginal delivery. But if there is no progress with the mechanical dilatation, we should go only for LSCS. The second option is we don't want to go for the mechanical method, and straight you can go for at the 37 weeks elective LSCS, because in this patient we have diabetes and anemia has been corrected, 30 years, and again the cardiovascular disease with all this risk, with the high risk consent, with having the anesthetist opinion and the cardiologist with a multi team, we will go for an elective LSCS at the completion of 37 weeks.
Right. Thank you, madam. Now, let us call the anesthetist. Dr. Basker, are you there? Yeah, fine.
Yes, sir.
So, if the choice is vaginal delivery, what will be your choice for labor analgesia? Or in case of any desire to go for LSCS, as in this case, what will be your preferred route of anesthesia?
So actually, as per Madam told, what she has told is very correct. The most preferred way of delivering the baby will be a vaginal route, and we can provide to start with an epidural pain relief. So we can start with an epidural pain relief, so that can cut short the second set, also to help the patient to deliver the baby without not much of stress. So, but my concern is, since the patient has undergone PCI, she will be on antiplatelet drugs. So it's a elective procedure. I would like to stop the clopidogrel at least 5 to 7 days prior. Aspirin can be continued, and a bridging therapy with unfractionated heparin, and stop going for before a regional, especially for an epidural, at least 4 to 6 hours prior. Heparin has to be stopped. Check the coagulation factors whether within the normal limit. Then you can go for an epidural, a graded epidural with a low dose. The local anesthetic can be should be used in a very dilute form, at least 0.0625% bupivacaine. I can add an additive like fentanyl. And if everything goes correct with epidural, we can deliver. And I have an advantage, since I got an epidural. If madam, if there's non-progression of the labor with the mechanical way of induction, then I can convert this as a with the dose increased, strength increase, I can take it for even for cesarean section also. That I have an advantage having an epidural. I can convert that for the pain relief epidural. I can take it to a regular cesarean section. This is the advantage with an epidural. But I have to keep in mind that we have to keep in mind that patient is under coverage of the antiplatelet drugs, and now we have gone to the bridging therapy. Fine. In that case, if the hemodynamic and everything is dependent on the hemodynamic stability of the patient. If the patient is not hemodynamic stable, then my preferred choice would be directly going for a GA, and there are the drugs where cardiac stable drugs like etomidate and coronary vasodilators and the vaporizing agents like isoflurane. This thing can be used. And if I am going to use, as our cardiovascular surgeon has told that about the anesthesia role, the drugs may cross the placenta like the opiates, but we are always having a helping hand in the form of antidote. We can the baby can be resuscitated if the placental the drugs have crossed, especially the opiates. If they cross the placenta and cause a baby depression, respiratory depression, this can be reversed. And there is not much of problem with the neuromuscular blocking drug. They don't cross the placenta, and we can provide a very safe anesthesia. But I have to keep in mind this patient has undergone a TCI, so any time the patient can go for any other problem, because the unfractionated heparin, it doesn't give any guarantee about a thrombus happening. So I have to keep those things in mind. And we have to work as a team with the cardiologist, with the obstetrician. We have to do, sir.
Thank you, Dr. Basker. I think before we proceed further, I just request to the panelists. There are about 26 unanswered questions in the chat question and answer session. So whichever you can answer, type and send an answer, that will be helpful as we continue to progress, because we are almost reaching the 9 o'clock time. So, Dr. Basker, I think both your messages are very clear that normal delivery, vaginal delivery, is the recommended mode of therapy, and cesarean delivery for a cardiac indication is only done if the patient has severe dysfunction, heart failure, pulmonary hypertension, not able to lie down, sick patient, hypotension. Those are the conditions where we can have a cesarean delivery. Otherwise, by and large, in a patient who is able to lie down and who's not very sick, vaginal delivery is the method of choice. Now, we find that the patient was admitted 36 weeks and she was asymptomatic. She was delivered by LSCS, and the patient was asymptomatic upon discharge and follow-up. What is the next slide? Yeah, now the question is, I think the poll you can launch. Now we have a patient who had a successful delivery, but however, probably nowadays, many mothers, they come back that they would like to have a child again. So can a subsequent pregnancy be allowed in this patient? I think we have about 35 of them have answered already. I think it is neck to neck, 50-50. Yes, no. I think the panelists, Dr. Roopali and Dr. Sampath Kumari, have to answer 50-50. So first, I think I'll ask the obstetrician. The patient wants to know if she can conceive again. What will be your advice and what are the concerns? First, Dr. Sampath Kumari and then Dr. Roopali. You are not audible, Dr. Sampath Kumari, you are muted.
Yes, sir. Yes, sir. I saw the audience poll 49 and 51%. It's really shocking. Definitely, I will not advise for the next baby, sir. Already she is having one baby and this is the second one. Again, the problem will be increasing. Already she is GDM. Already she had the stent and anemia is also now she will be more nowadays. As you told, the mortality with the cardiac cases is also rarely increasing. So I will counsel her with the contraceptive methods. See, permanent contraceptive methods means it will be difficult. At least the progesterone injections, DMPA injections, once in 3 months, it can be given. I will never advise her the next babies, only 2 babies. If at all needed, she can go, her partner can also go for vasectomy.
I'll give the tougher job to Roopali. Now this patient says, I want to have a baby, whatever you say, I'm going to have a baby. So what are all the situations or what are all the advice that you will do, or how will you going to use the situation to ensure that she has a safer subsequent pregnancy? And what are the concerns you will be talking to her, while taking the high risk informed consent?
So our case, which we are dealing with, is a case of SCAD. The good thing here, LV function has improved. What it's like at 4 weeks is 45%. If her LV has not improved, then I would have definitely said it's a very high risk, because LV dysfunction per se becomes like a very high risk pregnancy, and it's recommend not to recommend these patients to become pregnant again, because of different scores. If we see ZAPRIC scores or WHO scores, LV dysfunction becomes a very high risk pregnancy in these cases. The thing is, her LV has improved, but we know that with SCAD, there is increased risk of repeat SCAD in further pregnancies. So maybe 15 to 23% cases may have repeat SCAD. So I agree with ma'am that it should be avoided. But if she is like very adamant, then it should be like her diabetes should be under control. Good beta blocker in these cases, having a good heart rate in these cases, but that all strategies will not prevent her that, or not give her guarantee that, okay, he will not develop a SCAD in next pregnancy. So it should be an individualized approach. Like with SCAD, we have to give individualized approach. It is generally not recommended. Maybe a patient is very adamant, then all the other risk factors for developing atherosclerotic or any MI in these cases should be counseled in the patients.
So thank you, Dr. Roopali. Now it's time to answer the questions. Before that, I thought I'll share my take-home thoughts so that it will itself answer some other questions in the chat box. Though I had originally planned about 15 minutes time, and now because it's already late, I'll come only to the take-home thoughts. Initially, I thought I'll share with you some latest studies on acute MI in pregnancy. Now coming to the take-home thoughts, acute MI, though uncommon as pregnancy, is increasing. The numbers are increasing in the recent years. Pregnant women are 3 to 4 times more likely to get MI than non-pregnant women of the same age. And the most likely, the higher incidence happens in the postpartum than in the antenatal period. If you look at the most common cause of MI in pregnancy, it is atherosclerosis, followed by SCAD, dissection, 24 to 40%. Acute MI in pregnancy, there is a higher incidence of complications, a higher incidence of shock. In fact, the first largest series was by Nkayam, 150 cases of acute MI he published almost 2 decades back. And there is a very high incidence of shock, as high as 38%. In the recent studies, what they had shown that was pregnancy itself did not increase the mortality of complications of SCAD in pregnancy compared to a non-pregnancy status. But overall, SCAD itself has a higher risk of adverse outcome. And I think in the discussion also we discussed, conservative management is the best for stable patients with acute MI in pregnancy and low risk. Interventional management is preferred only for high-risk patients and unstable patients. In a patient with STEMI, coronary angiogram and if necessary, primary PCI. Unlike all other STEMI, straight away we go for primary PCI. In pregnancy, if you do an angio and you find that by the time the patient is settled down, it is 60 to 70% lesion or 70% lesion, good to me, 3 flow, no pain, we may not do anything, particularly if you suspect a SCAD. In pregnancy in SCAD with TIMI 3 flow, the best thing is conservative management. If an angiographic facility is not there, thrombolysis can be considered, streptokinase can be used, tenecteplase can be used. There is a higher risk of worsening SCAD and increasing the bleeding complications. Coming to the dissections, both iatrogenic dissections and extension of SCAD are very common during catheter engagement, dye injection, and introduction of hardware for PCI or imaging. Though imaging helps a lot in SCAD, it has its own concerns about hardware introduction. We need to be extremely careful. But however, the data has shown very clearly that the women who undergo invasive management for primary angioplasty have a lower in-hospital mortality than women who do not undergo an invasive management. The tablets, aspirin is safe for use in pregnancy. Clopidogrel is the preferred DAPT. The shortest possible duration pregnancy is preferred. And if you're doing a PCI, nowadays we have very good stents that can allow an extremely short duration of DAPT, just 28 weeks, and after which we can continue aspirin, and anesthetists are very comfortable with the single drug aspirin. So it is safer to withhold antiplatelet therapy before neuraxial anesthesia. However, in one of the series, there were 7 cases where DAPT was continued while regional anesthesia was given without any complications. Unfractionated heparin is the preferred anticoagulant. Low molecular heparin can be used. Statins in 2021, FDA removed it as a contraindicated drug in pregnancy, considering the fact that select patients can get a good amount of benefit, and making them a contraindication deprives them of benefit. A lot of studies have shown that statins have not been associated with congenital malformations. So it can be used if necessary. And I think Dr. Roopali also touched upon which statin that can be used. Subsequent pregnancy after PAMI, as we know that asymptomatic, no residual ischemia, no LV dysfunction, after 12 months, if the patient is very particular, maybe we can say that you can go ahead. The pregnancy with its own risk. The risk of recurrence of acute MI in subsequent pregnancy is as 10 to 20%. Risk factor optimization is most crucial. Dr. Roopali touched it upon. We need to optimize if there any kind, all risk factors to be optimized, and drug therapy have to be optimized. And particularly, there was one good study that showed that pregnancy as such does not increase the risk of SCAD subsequently. However, SCAD itself has a risk of recurrence. So it is very important that we counsel the patient not to go ahead with the subsequent pregnancy. Now, with this background, let us touch upon that. In fact, for everyone, the next one will be a case of Fontan's pregnancy by Dr. Navanitha Sashikumar, and the subsequent, that is in the month of July, we'll be discussing a case of prosthetic valve thrombosis in pregnancy by Dr. Annie Princy. Now we will have to answer the questions by our audience. I'll be sharing it to the panelists. Can it be possible that the pericardial effusion is associated with viral infection at times? It is definitely possible, but then it is very, very small amount. Dr. Jyotsna has discussed very nicely. Small amount of pericardial effusion can occur in pregnancy, yes. Now, STEMI, I think we have answered some of them live. What about conservative management? What is to be done for that? I think we answered it. Since the hemoglobin is low, transfusion is to be given before the procedure or care. Dr. Roopali, would you like to answer Dr. Satyajit's question?
Yes, sir. I think because any blood transfusion is a prothrombotic state, because we know when we go for these cases, and if we are finding that this patient is having around 8, we usually say that 8 is good enough. We can go for invasive, and you're especially going for radial in these cases. But if it is less than 8, a blood transfusion can be given in these patients.
Thank you. And is echo for all we do? In fact, it varies on the areas. If your institution can afford to have a routine echo, you can do it. In some of the institutions, some of the government setups, there is a routine echo is mandatory. They can do that. But in other places, I think you'll have to wisely use the facilities available, both HR and the infrastructure facilities available. To detect 1%, you may be putting 998 patients into forced echo. So, it has its own plus and minus. We'll not be discussing that here. Careful use of thrombolytic therapy has been used. I think we have discussed about thrombolytic therapy. Is there a need for intervention for LAD alone? Is there an advantage of mid-cap? No need for a CPB in the law. Of course, mid-cap has its own advantages, but then for a mid-LAD or a proximal LAD, if there is a critical one, even Dr. Jacob will agree that doing a primary angioplasty at that point of time is better than sending the patient for a CABG at this point of time. Is there any entity where young mothers can have a spontaneous caudal rupture? Dr. Jyotsna, Dr. Roopali? Easy questions I'll answer. The difficult one, I'll put it across to the panelists.
The spontaneous rupture, actually, the scared people are the likely to have the other arteriopathies. But arteriopathies are common, not the papillary muscle dysfunctions. So it is, if at all the papillary muscle dysfunction has to then occur, produce an acute MR is because of the infarct. So that is not that they are likely to have a more spontaneous ruptures.
And Dr. Roopali is our session editor. So she has a big job of answering all these questions and making them a document. So to all the participants, we'll be letting you know that there is a group called Cardio-Obstetric groups. If you're not there, please join. And, after a week or so, we'll summarize the answer for all these questions. And I think Dr. Monica and Mr. Vikrant, I'm sure you'll be sharing all the questions in the chat box to us, so that we can prepare the answers for it and distribute it to all the participants and others. So it will be helpful. Dr. Jacob, I think you wanted to speak something. Please go ahead.
Yes, Dr. Paul, it's about the minimally invasive that you are talking. We actually lift the whole breast up and then, get into the space under the breast. And for a lactating mother, I really don't think that would be a good idea. And it's so much more simpler and easier just to do a stenotomy and do a CABG if it comes to that. So I just thought I'll just add that point as well.
Thank you. Thank you. What are the anti-mitotic effects of agents used in the stents in the fetus? I think very insignificant. And Dr. Amrit Gupta, thank you, madam, for joining us. You have good delivery is not an outcome of a fetus, maybe as good in the situation is. As a fetus is already 32 weeks, can we do LS and send for bypass surgery? I think we have touched upon in more than 28 weeks. If the patient is going for a CABG, the patient can have a cesarean delivery and then go for a CABG. But this patient is not going for a CABG. The patient had a PCI. So the question of cesarean delivery and LSCS does not arise. For a primary hypertriglyceridemia, female going pregnancy, 3 months of amenorrhea, which drug is safe? Omega-3 fatty acids, persistent vomiting, bile acids, apheresis. I think this is outside the scope of today's discussion, but still, apheresis, I don't think it is available. Dr. Roopali, Dr. Jyotsna, you would like to make any comment? Dr. Annie? Primary hypertriglyceridemia, I think he is very clear about primary hypertriglyceridemia. Dr. Badri, if you probably, if you had looked at upon, you can maybe type the answer to. This is definitely not a part of today's discussion. How to manage antiplatelets during and after delivery? I think Dr. Basker and we have discussed it. Isn't it a recent contraindication for vaginal delivery? Recent MI is definitely not a contraindication. Please remember that, elective delivery will prefer to have it after a month after MI. But then it is not always possible for us. If the patient develops an MI at 38 weeks, the delivery is going to have. But most of the time, we'll be able to have a safe a month. And recent MI is not a contraindication for vaginal delivery, and it is not an indication for a cesarean delivery. And we had discussed this nicely already. And the recording, yeah, I think Dr. Vidya Manoharan, we have the recordings of all the previous 3 sessions, and they are available in this YouTube channel called Cardio-Obstetrics channel. And if you're not in the Cardio-Obstetrics groups, please let us know. Contact one of us, we'll add you to the group. And the present video and the previous 3 video links will be able to access it there. Will you stop DAPT if LSES is planned? Definitely. If LSES is planned more than LSES, we will be stopping DAPT. Surgeons and anesthetists are comfortable with the aspirin, but there have been situations where it has been done, but generally the clopidogrel can be stopped about 3 to 7 days before the date of elective LSES. And particularly with the shorter duration.
Can I just add one point, sir? I think with all that short DAPT trial and all that, if within 4 weeks and we have done a good job with the stenting, so then we can be comfortable in stopping the clopidogrel in these cases.
Exactly. Short DAP study is there. In SCAD using OCT, wouldn't that propagate? I think both OCT and IVUS are definitely interventional. We are taking devices inside. So OCT gives a better picture than IVUS, but anyway. Won't progesterone increase the risk of SCAD? What are they trying to ask? Are we giving progesterone during any of therapy here? No, right? Madam? We are not using for anything for induction. No, definitely not.
No. The madam said that for the contraception, madam wanted to give a progesterone of third monthly. Probably they asked that.
Okay. Madam, any comments on that? Sampath Kumari, madam? I think progesterone SCAD risk. I'm not too sure.
One of the theories for the SCAD is the hormonal imbalance, which is responsible. But I'm not sure whether progesterone itself increases that or not.
We'll answer this question in our
progesterone. Excuse me, sir.
Yeah, please.
In these conditions, we can go with progesterone, sir. If at all needed, we can go with the progesterone. Only estrogen is contraindicated. Progesterones can be given.
Okay. That is great. Why medical management of SCAD was not considered? In fact, that I think we have discussed all that. Stopping both antiplatelets, bridging with heparin, I think Dr. Roopali, it is yes. Am I right?
Yes, we don't have to stop both the antiplatelets. We are continuing with one antiplatelet and we are going ahead with the cesarean.
So we are continuing with aspirin and
we are continuing with aspirin.
Recent study, monoclonal antibody infusion can be replacing this heparin, which has a very short half-life, and it's also showing good results. You can use this thing also, monoclonal antibodies infusion.
Yeah. And for bridging, in fact, one more thought I had was if the patient is high risk for stopping DAPT, you can stop clopidogrel, continue aspirin, and start IV cangrelor. And you can continue this for a period of time, couple of days, and then just before delivery you can stop, because it is a very short work and it goes off, the effect goes off very quickly. So you can consider IV cangrelor in case if it's available in your situation, particularly if you're not able to stop DAPT. Say in 2 weeks after the PCA, the patient has to go for a delivery and you want to stop this one, you can stop a DAPT 5 days back or 3 days before and start cangrelor and stop it a couple of hours before the procedure. For contraception, Dr. Sampath Kumari, ma'am, would you like to make any comments here? What would be your preferred contraception for this patient after delivery?
Sir, contraception already I have told that we can go with the DMPA, depoxyprogesterone. That is the only contraception we can go. Now, usually we advise the vasectomy. Most of the time they will not be willing. So with the progesterone, DMPA injection is the best contraception for this type of patients. Or
So,
if they are willing, if they don't want, will not come for follow-up means in that cases we can go with the property incision also. It is not a contraindication.
I think thanks a lot. I think with this thing, I think we have answered all the questions in the chat box, though we exceeded the time by 20 minutes. At the outset, now it gives me the pleasure and privilege of thanking you. First, I would like to thank the participants, the audience who really gathered and encouraged us in good numbers. Couple of information to you, as I told you already. There is one group called Cardio-Obstetrics India, where we'll be discussing only issues related to cardio-obstetrics. You're welcome to join the group. And all the videos are available in Cardio-Obstetrics YouTube channel. You can, in a search Cardio-Obstetrics in YouTube, you'll be able to get it. You can subscribe. Today's session will be available too. Thank you once again for joining. Thank you for your active participation in the polls. And thank you for your, in fact, totally we had almost how many? 38 questions you had asked. In fact, some of them were very, very helpful. And we'll be sharing, I think Dr. Roopali is the session editor, will definitely get some inputs from all the other panelists and the speaker, and will provide you with a wonderful newsletter for the Cardio-Obstetrics Masterclass 3. Thank you all the audience for sharing. And I thank Dr. Jyotsna for being willing to presenting this case. That is very helpful to generate such a lot of discussion. And thank the panelists, Dr. Roopali and Dr. Annie, Cardiology Department. You have been very, very helpful, and your inputs have been very, very helpful. And Dr. Prabhakar, your inputs on the pharmacology aspects of it are very helpful. Dr. Basker, your inputs, thank you so much, particularly about the crucial inputs on anesthesia, neuraxial anesthesia and all that. Dr. Jacob, I think the first time we had a cardiac surgeon, we never had a cardiac surgeon in any of the sessions before. Now onwards, for every case, whenever there is a need, we'll have cardiac surgeons. And in fact, we thank you for supporting this venture. In fact, we have added a lot of cardiac surgeons to the group also. Thank you so much. And Sampath Kumari, madam, I think thank you so much. In fact, you're doing so much for this particular field. I thank all the panelists, and Dr. Annie Princy have been very, very helpful in setting up this program. And above all, I thank God Almighty for this wonderful privilege He has given us, that we all can join together, work together, and create a better environment for learning in this field. Particularly cardio-obstetrics is a field that India has to develop, so that the care for women with the heart disease will improve, and maternal death related to cardiovascular disease will come down in this country, and will be contributing and partnering with the National Ministry of Health and Family Welfare to improve the care of women with the heart disease. So thank you very much, one and all. And with this, we close the session. Thank you so much.
Thank you so much, sir. Thank you.
More importantly, I forgot to thank the Maddury team, Dr. Monica and Vikrant, who have been very helpful in setting this up. And we'll be continuing to working with you, Monica and Vikrant. We'll be needing particularly the questions that were asked in the chat box. Please share it to us. Thank you so much.